Okay, welcome everybody to this afternoon's webinar being presented by our awesome hosts, Julia Bowman and Sarah Edwards, who are with the Illinois School for the Visually Impaired Early Intervention Outreach. Our webinar today is ONH 101, What Families Need to Know. And so we're really excited to have you on. I know I'm excited to hear the information. I always learn something new from Julia and Sarah, always. They always bring something new to the table. So I really love being in these webinars. But in the meantime, while we are getting people rolling in to our webinar, I want to take a quick poll so we know who is here with us today. I launched a poll. So first thing we want to know is, what is your job title? Are you a teacher of students with visual impairments? Are you a low vision specialist, orientation and mobility specialist, a vision rehab specialist, therapist or teacher, assistive technology specialist, a college faculty or state administration, student in a college program? Are you a parent or other? And if you fall in the other category, please be sure to enter what category you are in into the chat, please, so we can recognize you and see who you are. Our second question: where are you from? Are you from the Northeast US, the Southeast US, Northwest US, Southwest US, Midwest US, Alaska, Hawaii, US territory, Canada, European country, or other? And again, in the other category, please enter it into the chat. And number three, how did you hear about this webinar? Through the APH website, through an email from APH, through university faculty, social media, ACB REP website, a friend or colleague, or other? So it looks like we have about 70%. We have about 111 people in the room, which is awesome. And of those, we have about 72% have participated. Well, we have some people from Australia. Welcome. Welcome. Okay, I think I will end the poll right now so we can just get a general idea, and I'm going to share the results. Let's see. We have 43% of our audience are TVIs, 4% are low vision specialists, 11% O&Ms or orientation mobility specialists, 6% vision rehab specialist, therapist, or teacher. We have 1% assistive technology. We don't have anybody from college faculty or state admin right now. 2% student in a college program, 14% are parents, and 28% are other. And there's been lots of activity in the chat letting us know who you are for in that other category. Number two, where are you from? Northeast US, we have 14%, 19% from the Southeast US, 8% from the Northwest US, 11% from the Southwest US, 36% from the Midwest US. We don't have anybody from Alaska, Hawaii right now. We have 1% from a US territory, 7% from Canada. We have a 1% from a European country and 1% from other. So welcome you all from a European country. And I know we have, and our other, I believe, would be Australia. And then we've got, comes from Sydney, Australia. Thank you, Carolyn. Welcome. Number three, how did you hear about this webinar? We have 17% APH website, 46% email from APH. We don't have any from university faculty, 5% from social media. We don't have any from ACB REP website. We have 27% from a friend or colleague, or 6% from other. So welcome, and thank you for letting us know this important information so we get an idea of who is with us in our audience today. My name is Olaya Landa Villard. I am the director of the APH Connect Center, and I'm always honored to have Julia and Sarah present for us. And so before we move forward, I'm going to pause our recording. All right, so now that we've gone through our ACB REP, just want to let you know we do have a 1-800 number information and referral line where you can give us a call. We actually have live people answering the phones to assist you with any questions you have. And the phone number to the APH Connect Center information and referral line is 1-800-232-5463, and we are available Monday through Friday, 8 a.m. to 8 p.m. Eastern Standard Time. So we are available on all of the if you're in the Pacific Coast, somebody will be available to answer your call until 5 o'clock your time. So we're really proud to have that, and we're really glad that we have really two excellent INR professionals who answer your phone calls. The documents that will be referenced in this presentation can be found at the aphconnectcenter.org/webinars website. Katie will put that into the chat as well. The webinar is being recorded, so you can find the link at the aphconnectcenter.org/webinars website. Once it is, give us a couple of weeks, and once it's cleaned up and ready for posting, it should be up on our APH Connect Center YouTube channel, as well as archived on our APH Connect Center website. We also have a Connect Center calendar where you can go to and see a list of all the events that are happening in your area. And that is at the aphconnectcenter.org/events website. And Katie, again, will be putting that into the chat. That is a calendar for the field. It is free to input any information that you have about activities going on in your area, or trainings, or parent meetings. So please make sure and take advantage of that. That is kind of like we're trying to make sure that that is like the hub for the field of events that are happening around the country and even around the world. So please make sure you take advantage of that. And to see a listing of our upcoming webinars, you can go to the aphconnectcenter.org/webinars website, or web link, and get a listing of any other webinars that we're giving in the future, so that you can make sure you register and not miss out on awesome information. So with that, I'm going to stop talking, and I'm going to hand it over to our wonderful presenters, Julia Bowman and Sarah Edwards. So welcome, and thank you, Sarah and Julia.
Thanks, Elia. As Elia mentioned, I work for the Illinois School for the Visually Impaired Birth to 3 program, and I have been in that position for about 12 years now. Prior to that, I was in the field of science. I was a chemist, but when my daughter was born 18 years ago, she was diagnosed with visual impairment, and she ended up having several visual impairments over the years. And we were fortunate enough to be in the early intervention program in Boston, where we lived at the time. And we were also welcomed into the Perkins Infant Toddler program. And that experience was so positive for us that I decided to change fields and become a teacher of students with visual impairments, and to focus on early intervention. It was a great career change, and I've never looked back.
All right, and my name is Sarah Edwards. My story is very similar to Julia's. I am the other half of the Outreach Birth to 3 program at the Illinois School for the Visually Impaired. Like Julia, I did not start out as a teacher or as a vision educator. I actually was working in the actuarial field, and I had my oldest child, who's now 19, and he was diagnosed with Leber's congenital amaurosis. So we were obviously involved in our early intervention program, and our DTV kept saying that she wanted to retire and that I needed to take her job because she couldn't retire until she found somebody to take her place. At the time, I really wasn't interested. I had another child. I have a daughter who's getting ready to turn 17, and she had Leber's congenital amaurosis too. So our DTV had to stick around for another 3 years in our home. When my daughter started the early childhood program, I did decide to go back to school, and I got my teacher degree with the low vision and blindness, and started work for the outreach program at ISVI. And like Julia, I've never looked back. I love my job. It doesn't feel like a job. I love seeing and working with my families every day. So with that being said, we'll get started with ONH 101, What Families Need to Know. So a primary responsibility of the birth to three educator is to educate our families that we work with every day. And Julia and I were really motivated to create this presentation to empower our families, to empower our parents and caregivers to advocate for their child with optic nerve hypoplasia in terms of their health and their well-being. In our experience with working with families, parents are often unaware of the behavioral and medical manifestations of ONH because no one has explained these issues to them. Their child has received the ONH diagnosis from their eye doctor, and perhaps they've been told what that means as far as their child's vision, but they've not been told any more information. They've not been told that there could be some behaviors, that there could be some more medical concerns associated with the diagnosis. So they walk away thinking or just knowing of the vision concerns. So when we receive a referral for a child with optic nerve hypoplasia and we go in for our first meeting and evaluation, some of our first questions to the family include, have you seen an endocrinologist? How is your child sleeping? How is your child eating? Do they seem to drink an excessive amount of water? Maybe some of these behaviors that we've observed here today, are those common? Are those typical behaviors for your child? Prior to this first meeting with us, many of our parents may have felt some frustration. They may have been scared. They may have been confused about their child's health or temperament because they had no idea that these issues or concerns that they've had could possibly be related to the ONH diagnosis. They might have been going along thinking that they were doing something wrong, maybe that they were just being bad parents, they didn't know what to do, or maybe their child was just being a little extra difficult. So we really need to provide our families with information. We need to help fill in those information gaps so that they can have those meaningful conversations with their child's medical team and seek out additional support if and when needed. The more knowledge we can provide our families, the more confident that they will feel. So we have to provide them information about their eye condition in its entirety. And once they become more confident, then they're able to advocate for their child. And that's really our goal. Our goal is to, help our parents become advocates for their children. As teachers of the students with visual impairments, along with the other professionals of other disciplines who work with children who have been diagnosed with optic nerve hypoplasia, it really is our role. It really is our responsibility to understand all aspects of ONH in order to address the development of the whole child. We have to understand ONH in its entirety so that we are in a position to share that knowledge with families and help them as they learn about their child's diagnosis. As we're going to discuss today, there are a number of issues and concerns associated with ONH. ONH involves ocular, neurological, and endocrine abnormalities. The behavioral and medical manifestations that we discuss and share with families, including the vision piece, often leads to many doctors, including several specialists. This means that there's a lot of information to process, to sort out, and just to digest. All of this information, most of our parents were unaware of when they received that initial diagnosis. So this is a lot. It's a lot of information, and we call it information overload. As parents, Julie and I, as we just mentioned, both have children with special needs, so we can relate and understand the process of receiving a diagnosis for your child. Upon hearing the diagnosis, it is very normal and very typical to go through a grieving process. And as professionals, we need to allow our families to do that. They can go through that grieving process and we need to support them while doing so. As we learn more about our child's diagnosis, then we can adjust. We start realizing how to move forward. What do we need to do? What does our child need from us? What does our child need from the other professionals? So as we learn information, we adjust. But as we learn new information, that can set us back to that grieving process. So it's an evolving circle. It's always fluid and always changing. So new information can set us back. We might have to do some grieving again. And then as we adjust to that new information, then we can start accepting that diagnosis again. Now, remember, I just said that with ONH, there's a lot of pieces. There's the ocular piece, there's the neurological piece, and endocrine piece. So with parents who have children with ONH, they might feel like this gal here in the picture getting slapped in the face with information. Once they receive information and they've adjusted to that, they kind of get slapped again with more information. So as professionals, we really need to be respectful and we really need to be sensitive in how we deliver or share this information. Julie and I have found that most of our families with babies in ONH, and research has supported this, have mommies that are very young mothers or first-time mothers. So they're just adjusting and learning how to be a parent. And then they're told that their child has ONH, which means that they most likely have a significant vision loss. And then we come in and tell them, oh, but there's more. There's more than just vision. So we have to be extremely sensitive. We need to be extremely respectful and individualize our approach on how we share information with them so that we can help them and support them. So before we start talking exactly about what ONH and what that means, we thought it would be best to just briefly give an overview of the visual system so that you can understand the structures and how the optic nerve plays a role in our ability to see. So to describe the visual system, we can follow the path that light takes. So if you look at the left side of the image of this eyeball, the very far left outer layer is the cornea. Light passes through the cornea first, and a majority of it is focused there. Then it travels through the aqueous and then through the pupil. And the pupil is that little black dot that we have in the middle of our eyes that dilates and gets big when it's really dark, and it constricts and gets really small when it's really bright. So the light goes through the cornea, aqueous, then the pupil, and it comes to the lens. And here in this image, the lens is that tan oval that focuses even more. After it passes through the lens, it goes through the vitreous, which is the jelly-like substance, the big orange ball in the middle of the picture here. The jelly-like substance, the vitreous, is what gives our eyeball its shape, the roundness, and the squishiness. If we didn't have the vitreous, our eyes would be flat and not squishy or round. Through the vitreous, it travels and it lands on the macula. And the macula is a point on the retina. The retina is the inner layer of the eye. They're on the back side of the eye. It's on the right side of the picture. The retina has millions of photoreceptor cells called rods and cones. Rods helps with the detail in our vision, and the cones help with our color. I always remember that C&C, cones and color. That's how I've always remembered it. Then those photoreceptor cells, all those cells travel through the optic to the optic nerve. They send their signals to the optic nerve, which then relays the message to the brain. Okay, so it starts with the cornea, goes through the aqueous, the lens, or goes through the cornea, aqueous, pupil, lens, vitreous jelly-like, goes to the macula, sends all those cells to the optic nerve, and that sends the message to the brain. That is then where the light is interpreted as a visual image, and this is what we perceive when we see. So if there's damage to the optic nerve, then that's going to interfere or interrupt that message being sent to the brain where it's actually interpreted. So what is optic nerve hypoplasia ONH? So we're going to start with the visual piece. So ONH is a congenital condition. It's characterized by an underdeveloped or small or even an absent optic nerve. And remember, the optic nerve is that bundle of nerves which transmit the message between the eyes and the brain. It occurs during pregnancy. That's why we say it's congenital. And the effects of ONH have a broad range that are dependent on the adequacy of how those visual messages are being sent from the eyes to the brain. Now, when you have a little one that's not had the diagnosis yet, parents may have noticed lack of eye contact. Maybe their child is just not able to fixate on things. They might notice some nystagmus, which we'll talk about all here pretty soon. They just might notice some absence or just atypical visual responses, like the vision is just off. All of those are red flags. All of those would warrant an eye exam. And the diagnosis of an ONH at an early age is extremely crucial. It's critical because there are conditions that are often associated with ONH, and we're going to share those conditions later. So the earlier we can detect ONH and get the child connected with the correct specialist, the better for their entire being. ONH can be diagnosed by an ophthalmologist. It can just be a regular dilated exam. It does not have to be a sedated exam. It doesn't have to be an exam under anesthesia, just an exam with dilation. If ONH is present, they will see a small and or pale optic nerve in one or both eyes. The picture on the left here is a picture of a normal or a healthy optic nerve, and the picture on the right is an image of a pale or smaller optic nerve. So that's just there for your comparison as to what they can see in order to diagnose optic nerve hypoplasia. So we call it the syndrome of ONH, and that's just because there's so many factors to play into ONH, and we'll discuss all of those today. But I always say I can have 5 kids with ONH in my living room and not one kid will be identical. This is not a one size fits all. It's not a one size fits all as far as their vision, the behavior, or their medical background. So there's a lot of factors and there's a wide variation among all of them. ONH is associated with deficits in their visual acuity, their visual fields, and nystagmus. Again, we'll talk about all 3 of these here pretty soon. It's important to remember, however, that there is a wide variation of visual functioning. So a child with ONH, their vision impairment with ONH can range from very mild. I've had kiddos with ONH that honestly, if they didn't have the diagnosis, it would be really hard to detect because they had really good vision or they were just really good at making their own accommodations. To extremely severe, to a severe bilateral vision loss. So there's a very wide variation of what a child can see. ONH is a stable, non-progressive condition. So their vision will not worsen over time. Now it is possible that one could have additional ocular impairments, and some of those additional ocular impairments could be progressive. So for example, a child with ONH could have potentially a retinal disease too. Retinal diseases are often progressive. So if you have a retinal disease, your vision most likely will decrease over time. But if it's ONH and ONH alone, their vision will not decrease. Their vision will not get worse. ONH is a stable, non-progressive condition. ONH may affect one or both eyes and of varying degrees. So when one eye is affected, we refer to it as unilateral. When both eyes are affected, we refer to it as bilateral. Again, when it is bilateral, the vision in each eye could differ. They could have one eye that is really, really good, really decent, and they could have the other eye with extremely poor visual acuity. So again, there's just a huge variation in their vision. Bilateral optic nerve hypoplasia usually manifests itself with reduced vision and nystagmus. Nystagmus is that involuntary rhythmic movement or shaking of the eyes. So if you have a little one that has some eyes that just kind of jitter back and forth, that is nystagmus. Nystagmus is often an early cue. We typically see it around 1 to 3 months of age. So if nystagmus is present, that's a red flag. It warrants an eye exam because nystagmus is often associated with significant bilateral vision loss. Nystagmus is associated with a number of visual impairments. So it doesn't necessarily mean that the child has ONH, but nystagmus is associated with ONH. So it is a cue. It is a red flag. A child with ONH and nystagmus will have difficulty focusing, and nystagmus could increase due to illness, fatigue, or even intense fixation. So at times it may be really mild and kind of quiet. If the child's not feeling well, then the nystagmus it may increase and become more intense. Another piece of ONH is strabismus. Strabismus is characterized by, excuse me, by an unequal action of the extraocular eye muscles. And there's actually 6 of them. There's 6 extraocular eye muscles. The imbalance of these muscles can cause a misalignment of the eyes, and the imbalance can be either horizontal or vertical, and it results in difficulties with functional vision. Strabismus is often secondary to visual impairment, again, one being ONH. It does impact the ability of both eyes to focus on an object, and the 2 images, and fusing those 2 images into one single image, which we call binocular vision. It's often noticed in the first year of life. So again, it's a red flag and can warrant the child to get an eye exam to determine if there is anything in addition. We typically see esotropia, which is a turning in of the affected eye. Exotropia is the turning out of the eyes, but typically with ONH, we see esotropia, which is turning in of the eyes, and typically it's unilateral, only one eye. So those with unilateral ONH may present with strabismus more so, or rather than nystagmus, because remember, nystagmus is associated with significant bilateral vision loss. So the incidence of strabismus may increase with unilateral optic nerve hypoplasia. Over the first 5 years of a child's life, we may see some minor or mild changes in the child's vision. Their vision may actually seem to improve. It's pretty common for us to hear from families after they've gone to some follow-up appointments when their child's been diagnosed with ONH. They'll come back after seeing their eye doctor, and the eye doctor has said, you know, their vision's improved, it's getting better. And of course, that's great news, and we always love hearing that. But we also see improvement over time while working with the families due to the child's maturity or just the result of maturation processes of the brain. So when you think about it, when we have a real little one, and I see this all the time, when I first get called in, the child may not even, you know, may just be months old, less than a year. And I can't get them to, I can't elicit any visual responses, not even to light, any shiny reflective, just very little to no visual responses. But then as the child gets older, they start reacting to light. I turn a light on, all of a sudden they pick their head up and start looking around, or they turn to the side if we shine a light here off in their periphery, or maybe I have something really shiny and reflective, or, you know, high contrast kind of in their very near distance, and all of a sudden they stop and look and start reaching out, but they've had no auditory cues, so clearly they were able to see. So we do see that, like, over time, they start realizing, like, wait a minute, there's something there. And even though we always say it's minimal to us and it may not seem like a lot to us, they're finding ways to use it. So they're using their functional vision better and more often as they get older and as their brain matures. Also, nystagmus can decrease over time. I was actually asked about a week ago, and then I was just asked again this morning if nystagmus completely disappears. It does not. So in general, if nystagmus has been established, it will not disappear, but it will diminish over time. From personal experience, I've seen that both of my kids have nystagmus. When they were younger, it was very intense, very wild. There was no mistaking that they had it. And now that they're older, I don't notice it as much. There are some triggers, like if they're really tired or not feeling well, that's probably the biggest time that I see their nystagmus intensify. In fact, I can tell them that they're going to be sick in a day or two because their nystagmus starts going crazy. So when I say, do you feel okay? They are like, oh no, because they know that they're going to be sick. And it's every single time. So it's just kind of a clue to watch, like internally, if something's happened, their nystagmus can increase. All right, let's look at the functional vision of someone who has ONH. So as mentioned, ONH is associated with reduced visual acuity and visual field loss. So one's vision can range from no light perception to good functional vision, or they may even have full vision in one eye with poor vision in the other. Depending on the damage of the nerve, visual acuity may range from 20/20 to blindness with no light perception. So as we mentioned before, there is a wide variation in vision. Vision is often characterized by lack of detail, but this lack of detail is not comparable to the blurred reduction in vision when we remove our glasses. It's just not the same. They may have poor visual acuity and are unable to focus. Due to the lack of detail, they may have difficulty recognizing our faces or facial expressions. So they may know that we're there and that our face is right here, but they just don't have the vision to see the details of our face. It's important to note that an individual's poor acuity due to ONH cannot be corrected with glasses. The glasses can only correct a refractive error, like a nearsighted or farsighted, or an astigmatism, which many of our kiddos with ONH, they can have an astigmatism. But glasses cannot correct the loss of vision due to an underdeveloped or small or damaged optic nerve. That's not treatable, it's not curable. I just wanted to point that out because I know that I have a number of families with ONH and the little ones will get prescribed glasses. So oftentimes it's not necessarily by the family members, but sometimes with other professionals, then they think that their vision is corrected. And it's not. Those glasses can only correct the vision up to a certain degree because the damage to the optic nerve cannot be corrected. In certain cases of ONH, a specific field defect may occur. Children may not be aware of people or objects in their periphery. So part of their visual field, whether it's an upper or lower half or even to the side, could be completely missing. They could just have a field cut. The effect on the visual field may range from generalized loss of detailed vision in both central and peripheral fields to subtle peripheral field loss. And again, it really all depends on the extent of the damage to the optic nerve and beyond. So we're going to talk about that on the next slide. An individual with loss of peripheral vision has some degree of tunnel vision. So tunnel vision is when they no longer, they do not have those side visions. So when we have peripheral vision, we know that something is presented to our sides or our upper and lower without directly looking at it. We can see someone who no longer has peripheral vision, they're not able to see those on the sides or upper and lower, and their vision is just kind of narrowed to directly in front of them. So that's the tunnel vision. If someone has tunnel vision, it makes it very difficult to gather comprehensive visual information in an environment. They might miss some information as they're scanning. And again, we talked about they might not have that detail. So even scanning pictures in a book, they'll maybe miss out on some visual information there. So it would be common for them to miss out on some important visual information without appropriate accommodations. All right, so the variable visual field defects are dependent on multiple factors. So we've mentioned, obviously, that it's hugely dependent on the extent of optic nerve hypoplasia, the extent of damage to the optic nerves and whether it affects one or both eyes. It also depends on the involvement of the optic chiasm. That is an X-shaped space located in the forebrain directly in front of the hypothalamus. The optic chiasmus is crucial to our vision. The optic chiasm is where the right and left optic nerves intersect, thus creating the hallmark X shape. So you have your right optic nerve coming out behind your right eye, left optic nerve coming out behind your left. They're going up into the brain and then they cross. And where they intersect or cross is the optic chiasm. Damage to the retina, if you go back to that image of the eyeball in the very beginning, the retina is that inner layer of the eye. Damage to the retina or one of the optic nerves before it reaches the optic chiasm results in loss of vision that is limited to the eye of of origin. However, in contrast, damage to the optic chiasm results in specific types of deficits that may involve visual field loss. So that's why it's important to know if the optic chiasm is involved, because it may impact some visual field loss. Another factor is the optic tract involvement. The optic tract is a continuation of the optic nerve that relays information from the optic chiasm. So it's composed of two individual tracts, the right and left optic tracts. So remember, the left optic tract corresponds to the right visual field, while the right optic tract corresponds to the left visual field because they crossed at the optic chiasm. Being that the optic tract is composed of both tracts, it carries retinal information relating to the whole visual field. So again, we need to know if the optic tract is involved and has any damage. Other brain involvement, such as schizencephaly, or maybe some effects from hydrocephalus, can play a role in how visual fields are defected. So it's really important that we know the complete story about what damage has been done, where is the damage. So MRIs are very important pieces of information for us. Depth perception. Depth perception is always a concern with kiddos with ONH, and it can be more severe if vision loss is great, excuse me, and or if unilateral. So depth perception is the ability to have like an accurate reach or accurate step or be able to locate things in space. So one way I can observe whether a child is struggling with depth perception, like if they're playing and their reach is a little off, it might be off to the side, they might have an over or under reach. Let's say they're trying to stack blocks or put on rings and they just keep missing that point because they're always off. That would be a clue that their depth perception is not completely accurate. If they're up and walking around, people with depth perception may struggle with some surface changes, walking off a curb or a step because they can't visually see that surface change, or maybe going from, hardwood to carpet. Children with ONH may be unable to locate objects in space precisely due to a lack of depth perception. So they're not able to find objects in space because their depth perception is so severe they can't visually locate them. All right. Children with ONH may also experience photophobia or sensitivity to bright light and glare. If this is the case, then we often see these children squint. They may lower their head to avoid the light. They may totally turn to avoid the light or turn their eyes. I've also had children that are just very hesitant and don't enjoy going outside. They don't want to participate in outdoor activities because it's just not comfortable. In fact, it can be somewhat painful. So that's something to keep thinking about when you work with children with ONH. Color vision is usually normal in affected eyes, but we need to keep in mind that there could be a variable color vision deficiency. So for example, they may see muted colors. Maybe their red or orange or yellow is not as vibrant as what you or I may see. They also may have difficulty differentiating between colors that are very similar on the color wheel, like blue and purple, or red and orange. They may have difficulty differentiating between those because they're so similar. And finally, ONH has been associated with amblyopia. Amblyopia is seen when one eye has a greater acuity than the other, and vision does not develop appropriately in the eye of lesser acuity because of the dominance or preferred better focused eye. In these cases, it's very common to have an ophthalmologist recommend patching of the stronger eye. So that forces the child to use that weaker eye and again forces that brain to make the connection, like we need to be working and using. So patching does work. I know it can be very frustrating and challenging at times, but I have seen it work if it's done consistently. So that's a common recommendation. Also, with amblyopia, and if you do have that really strong eye and really weak eye, then you will see some of those depth perception concerns with our kiddos. And before I pass it on to Julia to talk about the other pieces, I just wanted to say in summary with the vision piece, kiddos with ONH, it's just extremely difficult to predict that visual acuity potential because there are so many variations.
Okay, so now let's get into septo-optic dysplasia. We've already had a question about that, and for good reason. Septo-optic dysplasia is a point of confusion for many of my families. As Sarah said at the beginning of the presentation, when you get a serious diagnosis for your child, it's difficult to take in this complex medical information. And when you hear a diagnosis that doesn't seem to mean anything, I mean, these words, septo-optic dysplasia, what does that even mean when you hear that? It's even more confusing. It is controversial in the medical community. Some doctors, including Dr. Borchert, consider SOD simply to be a variation of ONH. And if you look at the numbers, I'll be showing you some data later, most kids with ONH have these features that are present in the diagnosis of SOD. And SOD has often just been generalized to mean any case of optic nerve hypoplasia plus hypopituitarism and or midline brain differences. But as I mentioned, most kids with ONH have these differences. So it's controversial whether we should just say ONH for all of these kids or whether it should be distinguished that these other differences are present. You might also hear de Morsier syndrome used for SOD. And that is because Dr. de Morsier wrote a paper in 1956, which described a patient who had already been deceased, but had abnormalities of the optic tract accompanied by an absent septum pellucidum. Now, given that this patient was deceased, we don't really know anything about visual functioning. It was just a report that was given, and there are actually some later resources where what we know as ONH/SOD today was reported. And one of those was by Hoyt, and that will be in my references section. So one of the common features, at least historically, with SOD is the double ring sign. But reading some of Dr. Borchert's more recent papers, he has found that the double ring sign is not exclusive to SOD or even to ONH, that the double ring sign can be observed in patients who have albinism and also in patients who have myopia. So just nearsightedness, you can have a double ring sign. So I thought that was interesting to find out. So this is what I want parents to know. SOD and ONH can be used interchangeably. So whichever diagnosis they get for their child, it kind of depends on which doctor they see. And any of these issues that I'm going to be describing now with the brain, with the endocrine system, and with behavior can show up whether the child has a diagnosis of SOD or ONH. So let's go. Let's go with the brain structures first. Three main structures of the brain are most commonly affected when a child has ONH. There are actually more. It's not an exclusive list, but these are the ones that most common are most commonly found. We see the corpus callosum, which is the connective tissue that joins the right and left hemispheres of the brain, which allows them to communicate. As you can imagine, that this is really important feature, allowing that connection and communication between the hemispheres. The septum pellucidum, that's actually a band of tissue that hangs perpendicular to the corpus callosum, and it separates the lateral ventricles. Now, what are the ventricles? The ventricles are the fluid-filled spaces of the brain. So if you've ever worked with a child who has hydrocephalus, you'll notice that they have enlarged ventricles of the brain. So that's that enlarged fluid-filled space there. Now, the hypothalamus, this is just an extremely important brain structure here. The hypothalamus is both in charge of our autonomic processes, such as temperature regulation, mood, sleep, and that falls into behavior, but it also controls the pituitary gland, which is the master gland of our endocrine system and directs the release of many important hormones. So this is just a little picture that I found online. I thought it was helpful just to show the different parts of the brain, and it is a slice. So you kind of have to imagine it more in 3D, just getting a look inside your brain. The corpus callosum is that question mark kind of in the middle. And inside it, it looks like the septum pellucidum is kind of tucked inside it, but really, as I said, it's kind of hanging down perpendicular from it. And then I think the easiest way to find the hypothalamus is to find the thalamus. So go up to the top and look straight down to the big orange section in the middle of the brain. And then right below it is the hypothalamus. So it's so tiny. It's such a tiny part of your brain. And yet it has a huge job. It does so much work in terms of those autonomic processes and hormone regulation. Okay, so how does this manifest? This is what I want families to know. When we start to have these conversations, I want them to understand that these issues are related to their child's diagnosis of ONH. Most often I hear about abnormal sleep patterns. This is so disruptive to a family's life. But as I just mentioned, the hypothalamus is the part of your brain that sets your diurnal clock. And it's a little funny, tiny part of your brain called the suprachiasmatic nuclei that set your daily clock. And if that's miswired, if it's not making that normal process, a child might have no diurnal cycle at all. So Dr. Borchert has done some research and has shown kids with, some sleep cycles that are off, some that move an hour each day, and some that have no pattern. And as I mentioned, that has to be just so absolutely disruptive. Temperature regulation is another issue that I have heard about, I've seen, I've observed in children, just being too hot all the time, too cold, and just being really uncomfortable. Severe mood changes, and these are above and beyond what you would see in a typical tantrum. So sometimes these severe mood changes, they seem to come from nowhere. They're really dramatic swings of mood, and they seem to be out of the child's control. Feeding difficulties. Now, in our population of little ones with visual impairments, we see a lot of feeding difficulties, but these feeding difficulties arise for two reasons. One, we have atypical sensory behaviors, which I'll talk about next, and then low tone, which includes oral motor muscles. So kids who are not able to chew and swallow and move food around in their mouth, as well as being averse to many food textures. So that adds up to some really significant feeding difficulties in our students. So as I mentioned, atypical sensory behaviors, they're going to be a big part of this talk because they manifest not only because of these brain differences, but also because of the endocrine issues that we're going to be looking at next. Low tone. That's when, we see children whose muscle tone is poor, they're floppy, they're not hitting their motor milestones very early. And so we're often working with a physical therapist, and also poor motor planning. So I see some babies, they try to reach, but their arm goes one way when the toy is really in a different direction. And it's more that their arm is not doing what they want it to do. So they have poor motor planning. Okay, so those are the brain differences. And now we're going to talk about the endocrine system. So I mentioned the hypothalamus is in charge of the pituitary gland, but the pituitary itself can also be misfunctioning. So you have two possibilities of why that endocrine system can be irregular. For whatever reason, the pituitary gland is such an important part of your child's endocrine system. It is in control of a number of hormones you'll see in my graphic here. These hormones that affect growth, weight gain, hunger, thirst, more important characteristics, such as bonding. That's what oxytocin, they say, is really important in bonding. That vasopressin, if that's sufficient, that can cause diabetes insipidus. There's luteinizing hormone is LH. ACTH is the hormone that is in charge of cortisol. Thyroid stimulating hormone, I'm just trying to read all the acronyms for you. Growth hormone, follicle stimulating hormone, prolactin. And that's just a short list. These hormone deficiencies can appear for the first time up to age 5. Sarah and I have this discussion all the time. When we first meet a family whose child has ONH, our first question is, who is your endocrinologist and when is your next appointment? And I know that might seem strange. You know, we walk in and we're the vision expert, but we want to know about their endocrinologist. But it's because these hormone deficiencies, you know, can appear later in a child's life. And we've both experienced this when families tell us, yes, we've seen the endocrinologist, we've seen them a couple times, and then they don't go back. That raises a huge red flag, because just for example, hypothyroidism can be detected at a mean age of 15 months. So, you know, well after the first year, these issues can appear, and they can be pretty severe. If they're not treated, they can be really, really severe and really affect a child's quality of life. So we just want to encourage parents to continue those regular endocrine appointments and testing, just to keep up with that, keep on top of the medical stuff there, and just make sure the child is happy and healthy. So here are those numbers I talked about. These data came from a study that Dr. Borchert ran, and it followed children from who were under 2 years of age up until they turned 5. And one of my resources at the end of this presentation will have that reference for you. He found that of all the students, all the little ones with ONH, 75 to 80% of them had hypopituitarism. So as I mentioned before, it's most of the kids who have ONH have these endocrine issues. Growth hormone is 70% have an insufficiency in growth hormone. Hypothyroidism is 43%. That was of this study of these children. 27% of these children had adrenal insufficiency or low cortisol, and 5% had diabetes insipidus. So this is just, as I said, one study, but it was, you know, it was a United States, it was a national study, and he had quite a large data pool. And so I think it's really important information for us to share with our families. So how does this manifest when we're looking at endocrine deficiencies? First and foremost, developmental delay, and that might surprise you, but if you think about early development, the thyroid hormone is actually critical in early brain development. So any deficiency in TSH could cause a developmental delay. So again, it's just so important to keep on top of these levels. Small stature, we do see many of our little ones with ONH who are lower on the percentile charts in terms of their height and weight. We do also see kids who are on the higher end, especially I see toddlers have an unexpected weight gain if some of these deficiencies kick in between say 2 and 3. I've seen some kids really gain a lot of weight there. And it can be because they're always hungry or always thirsty. Constipation is another issue that can arise because of these hormone deficiencies, as well as severe fatigue. And I think that has a lot to do with cortisol levels. So now we're going to look at behavior issues. And behavior issues, to understand the behavior issues, you really have to think about everything we've discussed before. The visual issues, the midline brain differences, and the endocrine issues, because they all just culminate to cause these behavior issues. And this is what I want parents to know, that there is a medical cause behind some of the functional things we see in kids with ONH. That, you know, this is not something that the child is acting out or the parent is doing anything wrong. It's medically based. So some of the things we see are atypical social behaviors, and I will get into that in a little bit more detail in the next slide. Language delays, and what's surprising about these language delays is that they're receptive rather than expressive. So we see kids not understanding or not processing language as well, even if they might be able to express their language. The next is sensory regulation. And this is different from just the, you know, atypical reactions to stimuli. This is being able to take in sensory information and then parse it out into little individual pieces, focus on the important piece, and then push everything else into the background. So that becomes a really big issue for kids in terms of lots of areas of development. And I'll talk about that a little bit more in detail. So tactile selectivity and defensiveness. I like to distinguish these two. For me, tactile selectivity is when a child is picky about what textures that they will accept and which ones they won't. Tactile defensiveness is when a child does not want to be touched. So they don't want to be touched, they don't want to be handled. So I like to distinguish those because I see them as two separate issues that we can work on. Low frustration level. I had a conversation with a family just last week, and mom was telling me her child had a short fuse. Just, any little thing would happen and just boom, explode. And it is beyond what you see at the toddler level. It's much earlier than you would see happen, and it's much earlier than the toddler years that you see just really, really limited ability to deal with any kind of change to the daily schedule, to routines, objects, people, and the environment. It's just like she said, a short fuse. Self-stimulation. This is not exclusive. We see this to ONH. We see this a lot in our population of kids with visual impairments, but the degree to which kids with ONH self-stim is much greater typically than we see with other types of visual impairments. And often it can slide into self-injury, which is just something no parent wants to see when their child is harming him or herself. Being able to self-soothe, that's a big part of it. Sometimes those STIM behaviors are the only way a child can self-soothe because typical strategies just don't seem to work. And finally, the sleep issues. As I said, the sleep issues are a culmination of all of the other issues we've talked about so far, but they are so very disruptive to a family's life, schedule, routine, and just ability to function. So digging into these behaviors just a little bit more, in terms of social, we know that in our population of little ones with visual impairments, we can have social delays because social skills are so visually based. But this is a little bit more than that. This is not really having any interest in engaging socially. So it's not just not being able to imitate social behavior or not being aware of it. It's just not having that interest. It's no joint attention. It's no seeking attention from either adults or children. And it's often accompanied with perseverative behaviors. So just taking objects, preferring objects over people, and then doing the same things over and over and over with those objects and not wanting to do anything else. As I mentioned, self-stim is often observed. And for my part, I have a lot of twirlers and spinners that whether they spin on their bottoms because they're not walking yet, or they're standing and spinning and spinning and spinning. I also have some bouncers and jumpers, just very busy little bodies, sometimes flapping. But as I said, they're just very, very busy in their bodies, always moving. And it's really hard to redirect that. So it's not just, they're stimming and then we can get them to play easily. It's really hard to break the spell of that self-stim. And then, as I mentioned, that can slide into self-injury. And it's my personal belief that these students are not self-injuring because they want to hurt themselves. It is just a greater degree of self-stim. Headbanging, biting, pinching, slapping. It's just a sensation, but that's not a medical opinion. That's just my own experience as a parent and a teacher. And then finally, that's sensory regulation. So whether it be sounds or textures, whether it be temperatures, no matter what the stimulus is, these children cannot focus on just one. They're very, very aware of all of their senses, everything they're taking in at once, and that can have some serious consequences for development. So we'll talk about that next. Sensory dysregulation implications. A lot of this sensory dysregulation shows up in language. And as I mentioned, our kiddos with ONH often have lower receptive language than their expressive language. So if you've worked with kiddos with ONH, you might hear them, they're singing their ABCs and they're talking, but they might not understand what they're talking about. They might just be repeating things that they've heard. And they might not be able to process what you're saying to them because their other senses are distracting. So they're really only able to focus on one sense at a time. And if any of their senses are giving them information that's distracting to them, they won't be able to use their hearing to process language. So I have an example of a student that I worked with who just could not stand the feel of his clothing. And so I would be trying to talk to him and have a conversation, and he would just come back with my shirt, my shirt, my shirt. Just couldn't stop thinking about the feel of his shirt on his body. And it was just so distracting. And he wasn't acting out. He wasn't trying to, not to focus. It's just that sensory information was dominating his thoughts at the time. So social skills is another area where sensory dysregulation shows up. And some of it is visual cues, just like any other child with a visual impairment. But some of it is not processing that social language. So as I mentioned, not being able to take your attention away from some other sensory stimulus and focus on the language that's being given. So some of these kiddos, they're just missing that social language for processing reasons, because they cannot shift their attention away from other stimuli. And then finally, we have the perseverative interests. So in the same fashion as the self-stimming, these perseverative actions can be calming. It's the way they self-soothe, these kiddos. That routine of doing the same thing over and over with a particular toy, they don't have to process anything new. It's calming, and it's easier for them to understand. It just makes more sense because it happens over and over in the same predictable way. Okay, so I need a drink of water before we talk about autism. So I'm sure, leading up to this, some of the information I was giving you on the previous slides, you can guess that I was going in this direction. There's a lot of controversy over the diagnosis of children with visual impairments in terms of autism. That either we find underdiagnosis because blindisms are used as a reason not to diagnose a child with autism, or we see overdiagnosis when there's not enough expertise on ONH in terms of the people doing the assessment, and especially in developmental pediatrics. Dr. Borchert has adapted the ADOS to address this somewhat. He still mentions that it's still a screening tool, the ADOS is, but he made it more appropriate for a child with visual impairment. Just thinking about some of the things that children are asked to do in these assessment screenings are making eye contact and having joint attention, and just these social skills that are so visually based. So it is adapted more like a play-based assessment, but he mentioned something in his paper where he talks about adapting the ADOS. It's the Williams et al. Paper, that he mentions that autistic-like behaviors might resolve after age 5 for a child with ONH. And in our field, it's recommended that we identify autism before a child is age 3. So it just kind of makes me wonder, whether it's helpful or it's less helpful when we're talking specifically about kids with ONH, but that's a whole can of worms that we can talk about another day. The last 2 points on this slide, these are taken from Dr. Therese Paletko, a paper that she wrote, and also from 2 presentations that she gave at ISVI last year. She is an expert in both visual impairments and in child development. And she talked to us a lot about kids with ONH and the diagnosis of autism. And the 2 big takeaways that I got from her are that when we're looking at social communication challenges, there has to be a cluster of features from both social and language to be autism. Hand flapping alone is not a diagnosis. So that was really helpful to me, because sometimes we get stuck on those perseverative behaviors or the self-stimming, and we're not looking at the bigger picture of all the social and language, seeing if there is a whole cluster of areas of skills. And then finally, she advised us to look at the child's overall developmental level. So looking at cognitive, motor, adaptive, social, and language, and then discern if social and language are very different from the other domains. So if we have a kiddo whose cognitive, adaptive are here and social language is down much, much lower, then that might be a red flag. But if we have a kid whose developmental levels are all the same, cognitive and social and motor are all tracking at about that same developmental age. That might just be where the kiddo is functioning. And it's always going to be a family decision about whether or not, they pursue that diagnosis. But that's very helpful to me when I'm looking at a child, and, we're always going to get questions about this as teachers, because this is originating from a visual condition. So what I want parents to know, I want them to know that many children with ONH do have delays in social and language skills. But as I mentioned, it's coming from that sensory dysregulation. So I want them to know why. Children with ONH are at higher risk for autism than the general population. And if you just want some numbers really quickly, the general population is, I think the latest data is 1 in 54. So that's a little less than 2%. And in the research, in the journals, we see anywhere from about 20% to 45% of children with ONH are reported as having autism. I think Dr. Borchert's number is about 30% in his paper. So it's kind of all over the place, but it is definitely higher than the general population. But that's not every child with ONH. So I always like to emphasize that to parents as well. Not every child with ONH will have autism. Autism assessments must be adapted for visual impairment. As I mentioned before, so many of the skills that are required in these assessments are visually based, require you to use your vision. And unless they're using that adapted ADOS, then most of these assessments are not adapted. And finally, if the child does receive the diagnosis, then the first thing I want to do when I'm supporting that child is start to adapt the interventions, because they themselves are so visually based. You think about picture schedules and visual timers and all of the visual strategies that are used in autism. And we need to think with our TVI/DTV hats on and address the ways that we can adapt some of these interventions for our students. So in conclusion, what we want parents to know is that ONH is a complex condition that causes visual impairment. There are also non-visual associations that include neurological, endocrine, and behavior differences. These differences may manifest as developmental delays or sensory processing issues or sleep or mood or any of the other issues that I mentioned in the manifestations. Sensory dysregulation, it's so key when we're thinking about kids with ONH, and it does affect both their social and language development. Finally, careful assessment must be performed when autism is suspected. And then these are the references that Sarah and I used when we put this presentation together. I'll just kind of point out the second from the bottom is a little pamphlet that you can share with your families. It's a PDF, ONH, a guide for parents. This is actually one of the things that sparked this presentation, because even the parent guide that was developed for families, we thought was so high level. So one of our goals in this presentation was to bring that level down to where we can have good, meaningful conversations with parents, and then they can have good, meaningful conversations with their child's medical team. Okay, and then we would like you to save the date if you're interested in joining us for part 2 of this series on ONH, where we'll be focusing on teaching strategies. That'll be happening April 11th at, I put 1 p.m. Central. I know you guys put 2 p.m. Eastern. And part 3, collaboration. It takes a whole team if we're going to properly support these kiddos with ONH. That'll happen on September 12th at 2 p.m. Eastern, 1 p.m. Central. And as always, please don't hesitate to contact us if you have any questions or just want to talk about ONH some more. We just think it's such an important area for us to focus on. We really appreciate you guys being here with us. And I know we have some questions. So I'm going to let Sarah start with the questions.
Well, I was answering most of them as I could. I saved one because I didn't want to answer it. I thought you might have more information.
Okay.
Because I don't know of any, but is there a relationship between ONH and diagnosis of ADHD?
So I don't know if there's a relationship. I know I've seen it diagnosed. I've seen both diagnoses occur in the same child, but I don't know if if it's documented in the research. I can definitely look. I mean, whenever you could probably notice many times I've mentioned Dr. Mark Borchert. He is our foremost expert in this country on ONH. So I'm always just checking back to see what his latest research is, if he has any information on that.
Yeah. And then some of them, so someone asked about OT and related service providers. So that part 3 in September will be, you know, how we work with other providers to work with kids. There's been a couple questions about genetics. So Julie and I talk about this a lot.
Oh yeah.
As well as ONH is genetic. We have come across a couple resources that say it can be, and both of us have had families with, you know, 2 kids who have ONH. So
yeah, it's really interesting. In the research, the only thing that's been documented, so like in peer-reviewed journals, is a de novo mutation. So not necessarily inherited, but just a mutation that shows up for the first time in a couple different genes. I think it's the HEX S1, and it's responsible for less than 1% of cases. So it's still really a small minority of cases, but there's new research out there that's whole exome sequencing, and people are trying to determine if there are more genetic causes of ONH. It's just our traditional genetic testing is kind of limited, and what you kind of have to know what you're looking for before you go find it. But this whole exome sequencing is kind of just like throwing everything together and see what you get. So that could reveal some more genetic connections in the future. I'm definitely keeping my eye on it.
right, yeah. And I saw another question: is your experience CVI and ONH can be diagnosed together? So I personally had some kiddos that have been diagnosed with ONH, and I highly suspect they have CVI just because of some abnormalities, you know, some brain damage and that, and they show some characteristics of CVI. So it's possible to have both CVI and ONH.
Yes, absolutely. And we had Dr. Roman gave one of our presentations last year at ISBI, and she mentioned that actually it works in the reverse too, that kids with a CVI diagnosis, now they're finding that some of them have small optic nerves. So there's definitely some connection there. But as Sarah said, I have had students who've had both diagnoses. And then I saw a question about, so, you know, how do you help these kids? And what I found is either the CVI or the ONH will kind of be dominant. That's just in my experience. So if you know, I have a kid and they're really responding to those CVI strategies, no matter, you know, if they have, no matter what other diagnosis they have, that's what I'm going to work on. But then I have some kiddos that their ocular functioning is just so limited that we can look at a light box all day and it's not really going to help them very much. So then we focus more on those tactile strategies, on, you know, using all of their senses, just things that I would do more with my students with ONH.
I had, sorry, I was answering someone's question and then I lost the question. It was about, shoot, now it keeps jumping on me. Oh, hearing impairments. Someone said, have you seen an increase in ONH kids with hearing impairments? I can't say that I have.
I can't either. I'm
thinking of all my kids who do have dual sensory loss, and I don't know that I can't think of any of them that actually have ONH. They have other ocular impairments, but not ONH.
Yeah. I did see a question early, while you were speaking, Sarah, and I promised I would come back to it, about causes. So not genetic, but just like, does anybody know anything about other causes? And I just wanted to reference Garcia Filion et al. At 2010. That's another Dr. Borchert paper. They did a study just looking at the maternal characteristics. And really, as Sarah mentioned at the very beginning, really what they found was just the young age of the mothers, that the age average was like 23 years old for many, many mothers of little ones with ONH. And also they call it prima parity, which just means firstborn. 76% were firstborn in their study. And then maybe some low prenatal weight gain, but no statistical correlation with any other maternal behaviors or health issues, nothing. So it was just the age and being a firstborn was the main link that they could find. That was really it. Oh, and one more, sorry, about the patching. There was a question about patching, and you had said when you were talking about amblyopia, they definitely do recommend patching, but it does depend on the relative strength of each eye. Because I have found some of my kids, they have no vision in their weak eye, and then asking them to patch the, the only eye that has any vision. I mean, that's a conversation families should have with their medical doctor, but as a teacher, that kind of makes me nervous, taking away all their functional vision in this early age when that visual development is so important. So that might be, just something to it's not always maybe something that you would pursue.
Trying to read some of the questions.
Yeah, I saw the question about why aren't the doctors encouraging families to follow up with endocrine? I don't know, but I know that that's why it's so important for us to do it. Right? I feel that we're the ones talking about all of the other issues with families, because they go to their doctor's appointment, they get their diagnosis, they get their treatment, and then they leave.
I would agree. I mean, most of the time when I go in for a referral for a child with ONH, they've had no idea about endocrinology. When I ask them if they've seen, nothing has ever been brought up to them. Not even like their pediatrician or there's just been no one to suggest the endocrinology.
Yes, I agree, May. Dr. Paletko, anything you can read that she's written is going to be helpful. I know she has a chapter in vision in the brain, and just anything you can find by her online is going to be really helpful.
Elia asked if, I'm trying to remember, if when we had Dr. Paletko come and do our ISVI, are they recorded and on our website?
No, she wouldn't let us record.
She wouldn't let us record.
But like I said, she has a lot of, you can get her PowerPoint slides of some presentations that she's done, and she's written some papers, and I have the reference on our resources page, so you can access that as well. We're getting so many questions, Sarah. I'm just trying to keep reading.
I know. So one question was, when does depth perception develop? So, okay, so correct me if I'm wrong, Julia, but my understanding is that depth perception is learned. So we just aren't born with depth perception. We learn depth perception.
Yes.
So for our children that have depth perception challenges, we have to implement those strategies and accommodations to help them, so then they can learn, that there's a step or a curve or whatnot. So it doesn't necessarily develop. I hope that answered their question.
Yeah, I think that's a good answer. And now I saw two more come up. In case you missed it, ONH stands for optic nerve hypoplasia. So it's an underdeveloped optic nerve. And I agree that SOD diagnosis does throw people off. So it really doesn't mean anything different. Honestly, a kid can have a diagnosis of just ONH and still have all those endocrine issues. So absolutely, like I said, when Sarah and I meet a kid and we hear their diagnosis is optic nerve hypoplasia, we come in and say, who's your endocrinologist? So even if they fall into that 25% or 20% of kids who don't have abnormal endocrine, they should still keep getting their testing until they're at least 5, because we know those things can just pop up out of nowhere. Just as 15 months is the average for hypothyroidism, and that's huge.
Right, but while you were talking, somebody asked you, it looked like they had a teenager diagnosed with ONH and they've never been to an endo. Okay. I would recommend going.
I would.
Because a teenager, we all know levels can kind of get wonky anyway. So, our body's ever changing. So I would definitely take them and get them checked out.
Just making sure I didn't miss anything else I said, because I know when you were talking, I said I would say answer all kinds of questions, but then Make sure I did.
What part does the optic chiasm play in light perception? I don't know that it necessarily plays a part in light perception. So the optic chiasm is where those optic nerves cross. And that can play a part in like their visual field loss if they've got some field cuts. I don't know that it plays.
Yeah, it's just part of the pathway that gets the information to the brain. Okay. I'm missing more. Oh, what should we take away from a VEP? It depends where you get your VEP. The ones I've been seeing these days have like percent vision rather than an acuity that comes out of them, but it just still tells you just kind of the level of visual impairment that your child has, like how diminished is their vision. So I really think VEPs are helpful information. So any families of mine who get a VEP, I definitely want to see that and go over that with them.
So the daughter has an absent optic chiasm but responds to light. Yeah. Go back up here, I thought. Explain the difference between optic atrophy and ONH.
Okay.
I've had a couple kiddos with optic atrophy as well. So Julie, I'll let you take it.
Oh yeah, sure. So optic atrophy optic nerve hypoplasia, let me start there. It's just when the optic nerve does not develop all the way, but optic atrophy is kind of, it decays a little bit. So some of it is died away, but usually I find that the optic atrophy is stable. So it's usually something that happens early or at birth or right after birth, and sometimes due to some maternal health issues, but then it stabilizes after that. But it is a wide range, just the same way optic nerve hypoplasia is. I have some kids with optic atrophy who have pretty significant vision loss, and then some who have really close to normal vision. And I've also had it co-occur with CVI. So yeah, that's confusing. We answered the causes. We answered about patching. I think I answered all the questions I said I would answer. Can you have both ONH and OA? That is a great question. I've never seen that myself. I think we'd need an ophthalmologist here.
I would agree with you. I've had kiddos with optic atrophy and CVI, but not optic atrophy and ONH.
Do we have an incidence? That's a really good question too. I don't know if I have the most recent data, but I thought it was like 1 in 10,000.
In Illinois, we don't have recent data because Illinois didn't put in any. So we
know that it's the number one ocular impairment though. CVI is the number one visual impairment in early years, and ONH is the number one ocular impairment. And I did see somebody say in there that it might be increasing, and I would believe that.
I believe that. I would say most of my referrals anymore are ONH. Somebody asked how important is an MRI. I'd say extremely. Just to know where that damage, that can tell us if there's any extensive damage and where. So most of the kids that I have ONH have had an initial MRI, at least in the beginning, when they're first diagnosed, they'll have an MRI, and then maybe a year or two later, they may request another one just to see if there's been.
Yeah, and some little bitty babies, they can't visualize their optic nerve so well in a regular eye exam, so they use the MRI to diagnose the small optic nerve.
Right.
Okay, what were we saying about a teenager? During puberty,
for a female with ONH, should an endocrinologist or other specialist?
Oh yes, please see your endocrinologist. So several of those hormones have to do with female reproduction. So yeah, that would be pretty important.
I have not seen optic atrophy dropped off the report, but again, we only see kids up until they're 3, and then they transition into school. So I guess it's possible that gets changed later, but I've not seen it in the birth to 3. Possibly a neurologist could recommend for an MRI to be done. Um, maybe even your pediatrician could have an MRI completed.
Who would make the recommendation for an MRI? Usually the neurologist.
That's what I was saying, but
sorry.
I think our pediatrician has referred for an MRI.
Yeah, if they can't
also.
visualize the optic nerve, but they suspect it, they might. It says why we see kids with gross motor delay. That's because of the corpus callosum in most cases. So that either missing or thin corpus callosum, that is responsible for the communication between the brain hemispheres. And I think it's just a miscommunication there. And also just, having just having the abnormal hypothalamus sometimes that can affect the motor delays, but we know that any kids just overall with those midline brain differences tend to have low muscle tone. Like I said, we're not medical doctors. We just wanted to put this in a language for parents, and it is so confusing. It is really like you really need to be a medical doctor to understand this enough thoroughly. But as I said, we just want to make this something that parents can use for their own advocacy.
Oh, thank you.
Yeah, we'll make sure everybody gets access to that parent guide and all our references. Just making sure we didn't miss anybody. We love all the questions. Thank you guys so much.
Yeah, and all the comments, much appreciated.
Appreciate it.
St. Louis, yeah, St. Louis has a good department.
They do.
I'm glad everyone found this so informative, but that's part of why Julie and I did this, because I mean, we're like, there's not much out there about ONH.
No, and we're always looking for more information and resources. And we would love to see like a community build up around ONH where we got together more and talked more.
And as far as our PowerPoint, we passed along like a
PDF?
Yes, PDF to.
Yeah, you'll be able to access the information on our slides just in PDF form. Thank you, Deb. If you missed her comment, one of my parents of my former students is on here making nice comments. But her kiddo, oh, another one. 2 of my former students are on here and my superstars at that. I'll say this, I love working with kids with ONH because they are unique. They are their own little individual people. And I think they have so much potential in so many different ways. So I love it.
And such a wide range of abilities too.
Yep.
No, I mean, it's great. Wow, your baby was diagnosed at 11 days old.
Wow.
That's impressive.
That is impressive. Good medical center.
Absolutely.
Yeah, but giving no real information, that is common. That was our
looking at some of the comments in here. Somebody mentioned that they listened to Chris Sabine, an adult with ONH. I'd love to be able to get a hold of him.
He has his own company, I think, and just talking about his experiences with ONH and sharing it with people.
Well, like, how could I find him? Because I think that would be, if you can share that with me later. I don't want to take any other time, but I think that would be he would be an excellent candidate to, I know he presented about it, but like for us to be able to put together either a webinar or videos or something that can talk about, an adult at living with ONH and what his experiences are. And that way other parents can see, you know, your kids can do do awesome things
Right.
even though they have this diagnosis. Because like some of the comments I've seen in here where, you know, parents are given the diagnosis and say, you know, kind of, okay, see you later.
He has
You know,
a
it's
blog
like,
on Paths to Literacy, Elia.
uh-huh.
You look him
Yeah,
up on
Path to
that.
Literacy is a good, very good resource as well. Yeah. And you said that's where Chris, he works.
He has a blog on there. Yes. If you go to
Okay.
Paths to Literacy and you go to blogs, you can probably find
Okay.
it. But I can send you a direct link later.
Yeah, that would be great, because I would love to be able to get a hold of him and have him enhance what you guys are doing here. So yep, we're at the end of our time, and it's like we could just keep going on and on. There's so many questions and comments, but that's why we have part 2 and 3. So we're looking forward to that as well. So make sure you all who have attended today, you sign up for those part 2 and part 3 coming up in the future here. And I appreciate all of the awesome information that you always bring, Julia and Sarah, and people in the chat are definitely are affirming that. They're like, you guys always give good information. I'm like, yeah, I know. I love it. That's why I love having you guys do this stuff, because y'all, you know, you really do provide some very helpful information and understandable chunks, you know, for families. So we really thank you for providing all this awesome stuff. And I'm going to pause for just a second. Okay, so yes, thank you, Julia. Thank you, Sarah. And we look so forward to having you for part 2 and 3. And thank everybody for your participation. We had about 140 or so attendees, so there's really great. So hopefully all of those 140 will continue to put out the word, and we'll have more people join us for our training. So thank you everybody for attending today, and we'll see you at part 2 on April 11th. Thanks so much, everyone.
Thank
Bye-bye.
you.